Hello, Ingrid. Thank you so much for joining me this early in the morning. So we are here. We decided in the end, because Facebook was being so reliable, we decided in the end to do a pre-recorded Zoom session. So Ingrid and I are here very early in the morning before hopefully any of our family burst in. And we're just going to have a chat about recurrent miscarriage. And it's really nice to be sat here with Ingrid because I was one of her patients not that long ago before I had my son Fitz. So it's really, really nice.
Yeah.
Ingrid, perhaps you could explain just firstly for anybody. So we've done this not just for people who are experiencing recurrent miscarriage. We're also we've done this for people who might have family who are experiencing this or who just want to find out more information about it. So I don't know if you could maybe just explain to people what recurrent miscarriage is, sort of what qualifies you for it, and how that sort of fits in with what you do.
Well, it's an interesting question in itself because I think we've started to change our view about what constitutes recurrent pregnancy loss. I guess when I was training, it was absolutely that you'd had to have 3 miscarriages in a row, and that was the only thing that would get you into the door of a recurrent miscarriage clinic. I think we're now appreciating that it's harder than that, and that by the time women have experienced 2 pregnancy losses, it's really important that we start to think about offering them support if they want it. So we've quite recently changed our kind of criteria really, so that once someone has experienced 2 pregnancy losses or more, then we're happy to see them in our service. Doesn't mean we always get to the bottom of it, but it does mean I hope we can offer women support.
That's amazing, because I always found 3 was, it felt, I mean, at the time, it felt like a very arbitrary number. You know, it felt like, oh, 3 is a nice round number, let's just pop that on there, you know, whereas I know certainly it felt very, I'm trying to think of the right word, it felt very sort of technical, that number. Do you know what I mean? Especially when I was going through it.
I think that's right. And I think for me, it's all about getting people to the end of this journey, whatever it is. And for different people, I think, you know, some people actually don't want to come and see me after however many pregnancy losses. They feel differently. But I think it's really important that we can offer access to investigation and treatment. Before that, there doesn't seem to be that much evidence that there is a magic number of 3. I say that we're just in the process of some quite exciting genetic work at the moment that suggests that the more miscarriages you have, there may be more likely to be an underlying genetic predisposition. But nevertheless, if you're a woman or a couple in the middle of pregnancy loss, as you say, there's just not a magic number, is there?
No, definitely doesn't feel that at the time. So now I'm obviously using the wrong terminology because you're using pregnancy loss, which of course is correct, because it might be somebody who has, you know, lost their baby further along as well. So I'm guessing that you see people, is it right in saying when you term a pregnancy loss, it's as soon as you see those lines on the stick, that's termed? And
yes, and that's what sort of we look at. Or indeed, of course, some people may have had 1 or 2 miscarriages and an ectopic pregnancy, and an ectopic pregnancy is no less an event, or, you know, a terrible thing to go through for someone, and sometimes it can be even worse. So I think that's why we term it recurrent pregnancy loss, because I think if you're the woman in the middle of that situation, for me to say, aha, it was only a biochemical pregnancy loss or only a ectopic, actually, that's not okay. It's we need to think of people in the whole, don't we, and not compartmentalize it. I think
that's just so refreshing to hear. We had a discussion the other day between 4 women who had sort of experienced various forms of baby loss, and we've also had other ones with sort of women and partners who have experienced baby loss further along. And one thing that we all sort of came to the conclusion was you feel very like a number. Often you feel like you're in a system, you're a number, you're in a category almost. So it's really, really nice to hear you talking that way. It's sort of, yeah, I think that will be really reassuring for a lot of people out there. So you will see people. How do people kind of access you? Do they go to speak to their GP? Can they refer directly? What's the sort of referral process?
So women can't refer themselves. That's just the process of the NHS. You have to be referred by someone. More and more now, though, you know, most of the women that come to our clinic have already been seen in our early pregnancy assessment unit somewhere along the way. So again, what we try not to do is say, well, go back to your GP and then your GP can refer you. So we've got a fabulous bunch of nurses that lead our pregnancy unit. What they will normally do is, if they've met a woman with recurrent pregnancy loss, they will refer that woman to me, because otherwise, you're weeks and months down the line, and then you've seen your GP, and then you go around the houses. So probably 50% of the women I see come by the early pregnancy unit, the rest are referred GPs.
Ah, that's brilliant. Thank you. Sorry, we lost you slightly there. You turned into a bit of a robot there. That's really, really reassuring and really happening now. So suppose this is a really open-ended question. What causes recurrent miscarriage?
So I think the real problem with recurrent miscarriage is there isn't a cause. So very rarely does someone come to see us and we go, aha, we found it, this is the reason, and that's what we can fix. And that is also what's really difficult about recurrent pregnancy loss, but because for most people, the most likely thing is it wasn't the same reason every time that you lost your baby, that sometimes it may be because, and probably the commonest reason even still, is that we know that pregnancy loss is highly associated with chromosomes of an embryo not being compatible with a normal developing baby. And that's the commonest cause of certainly pregnancy loss. But if you've had, say, 3 or 4 miscarriages, it's quite likely that 1 or 2 of them related to that, and that perhaps 1 or 2 of them related to something else. So therefore, it's one of the real problems in kind of understanding and researching miscarriage, is that we're not just necessarily looking for one underlying cause. There's probably a whole set of reasons that it might have happened. We do, however, know that the more pregnancy losses a woman has, the more likely it is that they might be actually chromosomally normal. And there is good evidence to suggest that if you look at miscarriage tissue from women who've had lots of miscarriages, actually that may well be the case. And therefore, there are other things that we know that underlie miscarriage. We know that sometimes things like thyroid dysfunction, if you've got abnormal thyroid hormones, that may just predispose to miscarriage. We know that lots of what we call autoimmune conditions, of which actually thyroid conditions are one of them, but autoimmune conditions seem to be associated with miscarriage. And there's a really big difference between saying something's an association, so it's linked to it, or something actually causes it. But we know that, for example, one autoimmune condition called antiphospholipid syndrome does seem to be very strongly associated with miscarriage. And in that condition, you have proteins or antibodies that seem to have an effect on how the placenta works. We know that sometimes people can have genetic rearrangements in their own genetic makeup, so something called balanced translocation, that either they or their partner carry, so they've got ultimately completely normal amount of genetic material, it's just slightly stuck in the wrong place, and that can predispose to miscarriage. And then there's probably the sort of big black box of miscarriage, the bit that none of us really understand very clearly yet, which is the lining of the womb, the endometrium. And that's the bit that lots of us are trying to look at and research and understand, whether there are hormonal factors within the lining of the womb, whether there are immune cell factors in the lining of the womb, or indeed at the moment we're about to join a study where we're looking at possibly facial or low-level infection and whether those things can affect miscarriage. So I think the long answer to your question is that it's really multifactorial, and for any one woman who's experienced recurrent pregnancy loss, it's not necessarily going to be the same as every time. And the other factor that's just important to remember is recurrent pregnancy loss, like all pregnancy loss, definitely gets commoner as we get older.
Yeah, because that's a definite one, isn't it? It's interesting when you're saying about the chromosomal abnormalities, because of course what I was going to ask was, I know sort of for people who are undergoing IVF, they're always sort of, told to get their eggs in tip-top condition, and you sort of think, well, does the same go with pregnancy? Does that, it's one of those things which I certainly, after I had my 3 miscarriages, I read every single book on the subject. There was sort of one book on miscarriage, which I kept reading and bursting into tears as I was reading it. My husband was like, why are you reading that book? And I was like, because I have to fix this. And, you know, he was very practical. He was very, there might not be anything to fix. It might just be bad luck, which is what a lot of people...
You're cutting out on me.
Shall we, let me move to the, hang on one second. Right, sorry, slight change of location because of technical difficulties. So yeah, it is interesting that you sort of talk about all of those, because I know it was thought that it was something to do with the lining that was affecting when I had my 3 miscarriages. That was one of the things. But I can remember also sort of reading about these chromosomal abnormalities, and of course people put the fear of God into you about the as you get older. And I think I was 34, 35, and of course I was going into a complete panic that my eggs were too old, and you know, taking vitamin E by the bottle load. But I mean, it's difficult because I'm guessing is there something that people can do, because you feel so sort of helpless in that situation?
I mean, I think the important thing to know in that situation actually is that there isn't anything you can do about your egg quality, because I think part of the problem with miscarriage is this blame game that we all do. As you say, oh my God, I'm too old. You know, oh, why didn't I get married 10 years earlier? I mean, it's not, these aren't stuff we can change in our lives. And we know that all women are born with all the eggs that we're ever going to have. So they're all formed whilst you're in the womb. And therefore, essentially, you do get genetic damage to those eggs as the years go by. And that damage definitely, those changes occur in the sort of later part of your fertile life very rapidly. But there's a lot of stuff out there that, you know, people may be sold to rejuvenate their eggs, but actually there's no evidence that we can change egg quality or indeed measure it terribly well, unfortunately. So it's not something that we can do something about, but it's something that's important that we explain to women is not their fault.
Yeah, I think that's the biggest thing, isn't it? It's just it's nothing that you've done. It's something that we talked about with, we had Steph, who's my husband's cousin, and she had a miscarriage at 8 weeks, and she said it never really occurred to her that she could have had a miscarriage, and then of course was researching all the things that she could do health-wise. You know, did she sort of miss this or that out? And it is so hard saying to people, it's just, this is just not your fault.
Yeah.
So it's quite interesting when you sort of talk about the genetic link, because I can remember having a really interesting conversation with my mum. She said, oh, I used to have extremely heavy periods some months, and I do wonder if we'd lost, you know, we'd had a similar, because obviously you just didn't know, did you, back in the sort of 70s and 80s that you were pregnant? What's the genetic link? Can you explain that?
Well, we're just about to publish some data with some really close collaborators who work on massive data sets of genetically analysed individuals. So this is something called genome-wide association studies. And although we've still got a long way to go in starting to understand what's happening and still looking for bigger data sets of women who've experienced recurrent pregnancy loss, we do see genetic signals that suggest that some women may be predisposed to recurrent pregnancy loss more than others. And it was quite clear in that recurrent pregnancy loss group more than in sporadic miscarriage. So, you know, these things are good in that eventually, you know, we're a long way from having the test that's going to tell you, but these types of analysis are really, really helpful in just starting to tease out, hopefully, what the kind of pathways might be that ultimately can also help us lead to treatments.
So, I mean, are you more predisposed, if you've had a parent or a grandparent who has experienced miscarriage, are you more likely to I
think it's not quite so clear, except of course if, for example, your mum had a balanced translocation and so have you, then absolutely you're going to be at more risk of a miscarriage. But it's a little bit more the other way around, that if you look across whole populations, there are certain genetic signals that seem to be clearer in women who've experienced recurrent pregnancy loss. I think it's not quite the same as saying I'm more likely because my mother was more likely, because part of the reason is it's so difficult with recurrent pregnancy loss is we talked about earlier, this kind of multifactorial thing. If your mum had her kids when she was in her 40s, but you had your children in your 20s, you may experience very different risks of miscarriage happening to you. There's so many different factors involved.
Yeah, and so I come at this as my husband's a scientist, and he is also banging his head against the wall at the way I come at these things. It's very hard though, isn't it? Because for lots of us who haven't had, sort of any kind of scientific, educational training, it is quite difficult to then, we want these easy answers. It's just hard. So can you tell me what happens? Let's take our couple. They've been referred to yourself. So what happens when they step in through the door?
Well, stepping through the door, if only they did. At the moment, I speak to them on the telephone, but I'm missing seeing faces. But yeah, so when couples are referred to us, I always prefer to see or speak to the couple if at all possible. We sort of take the story from that couple. What's happened? When did their miscarriages happen? Were they had operations? What treatment did they have to have? And then information about the individual. Are there other things that might be associated with miscarriage? Polycystic ovarian syndrome, for example, diabetes, other clinical things. What are their ages? Because for women and indeed for men, there's definitely an association of age with miscarriage. So it's about taking a history. It's about working out what's important for people right now. And then a lot of what I do, or at least I hope I do, is explain what the underlying issues are with miscarriage, what the chances of it happening again are, which of course for most people actually is a pretty positive story. And that's the one thing I often try and get people to walk away knowing, is that all is not lost. That we do organise relevant tests and investigations. So we do blood tests to look for the autoimmune conditions that we're looking for. We do blood tests to look for inherited factors that may be associated with blood clotting, because we're part of research studies where they may enter into trials to treat those things. We look at the shape of the lining of the womb. We sometimes look at hormone levels. And we talk about the fact that very often, actually, we're not going to, we do all this sort of battery of blood tests, and we're not going to necessarily come up with something that's the magic solution. And then often a lot of the time is spent saying, right, how are we going to help you in the here and now? Is there support that we can offer? We are really lucky at the John Radcliffe in Oxford that we've got excellent support, counselling support, which very many women wish to access. We talk about what's going to happen next time. So, what are you going to do when you're pregnant? And again, what we like to do is not sort of send people around the houses, but people do have direct access back to the clinic. And again, I'm very lucky. I work with a great nurse specialist, a nurse practitioner who tries to offer continuity of care for my patients when they're pregnant, because a lot of muddling people through those first 12 weeks is often, I think, the most helpful thing we can offer. We talk about research studies that we're undertaking that at the moment in COVID is a little tricky, but we're sort of getting stuff back on track and getting stuff up and running again now. And then we talk about what do we do if we don't find anything, and are there treatment options that you might wish to try. A lot of the time, I spend a lot of time talking about what we shouldn't do, because anyone who's experienced miscarriage will know that there is this incredible world out there of things you can buy, medicate, over-the-counter stuff, specialists you can go and see, money that can be spent, often not on things that are evidence-based.
I was going to say, quite a lot of the things that were doing the rounds were on I can remember when I came to see you and I asked you about natural killer cells, and that had just been, hadn't it? The doctor who had sort of championed it had very bravely said, well, I don't think it's quite as simple as I said, or that they didn't exist.
Well, they absolutely exist. So we know natural killer cells exist. They're really important. They're really important for the normal process of implantation in the womb. And so we know that, they're a vital part of making a healthy placenta, for example. There's been some evidence or some studies that have suggested numbers of NK cells in the womb may be associated with recurrent pregnancy loss. But again, I think exactly as you say, it's not as simple as high numbers, treat with something, that it's all fine. That evidence just isn't there. And probably more importantly, lots of women go and have blood tests to look at natural killer cells. And they're a completely different set of cells that you know, probably don't reflect anything that's going on in the womb, in all honesty. So there's a lot of stuff out there that intuitively looks great, but the reality is the evidence just isn't there that testing for these things, and certainly using treatments, results in a higher chance of a baby.
And so an interesting one that I noticed from my pregnancy, my first pregnancy, and then my first successful pregnancy, I should say. So it's my fourth pregnancy to my sixth pregnancy, was, which both were successful, fourth and sixth, was the fact that progesterone was much more readily prescribed, which was absolutely amazing. I can remember that was the first thing that you said to me was that, you know, so I mean that's undergone a change, hasn't it?
It is probably changing. It's a really tricky one. The progesterone story is very interesting because there's a very, very good trial published in 2015 that many people have read about called the PROMISE trial. And in that study, women who'd had 3 or more pregnancy losses were randomly allocated either progesterone or a dummy placebo drug. And unfortunately, like many of the trials in recurrent miscarriage, it didn't show benefit. And then last year, probably 18 months ago now, there was another study, very different, called the PRISM trial. And in that trial, it wasn't particularly looking at women with recurrent pregnancy loss, but it was looking at women who were bleeding in early pregnancy and looking to see if those women were allocated progesterone or a dummy placebo, was that going to increase the live birth rate, reduce the miscarriage rate? And it was an enormous trial of more than 3,000 women, you know, right across the country. And unfortunately, again, it didn't show a benefit. And we were all, again, you know, all these great trials are undertaken, particularly in Birmingham, and it didn't show benefit. What those authors have done, though, they have put that data together with the PROMISE trial data, together with some other data. And when they look at subgroups, they think that actually there may overall be of a benefit for women with recurrent pregnancy loss. It's a really difficult one. My hunch is that there probably is a subgroup of women for whom it's a benefit. And that's why they find this when they put all of these different trial sets together. It's not at the moment within any national guidelines yet to be using progesterone, but my own view is that, you know, people take responsibility for their own healthcare. We know this is a really safe drug, and what I now do is explain the data, talk about it, and say if this is, you know, it isn't barn door clear to me, but if this is something you would like to try, then that I think is fine. It's not usually prescribed by a GP, and that again is absolutely fine because it doesn't sit yet within any national guidelines. That may change over the next 12 to 18 months, but for me, I think it's just really important that we explain the evidence of the research that we do to women, and that women can make choices based on it.
It's so hard, isn't it? Because all you want, and I can remember this so vividly, all you want is what will work. You just want it fixed.
And I think the thing I find really hard, even about this progesterone stuff actually, is that as a doctor, I think it's really important we do that stuff that's evidence-based. And therefore, I completely get somebody coming to me and saying, do you know what, I don't really care what you tell me to do, as long as I get to do something. But actually my job is not to throw a load of medications at someone because we can, but I think the progesterone evidence is probably starting to grow, and I think it's likely that will be something that comes into sort of normal clinical practice. And as I say, you know, it's just really important, as long as we can explain the data, explain the evidence, women should, I think, be able to make choices about things that might work.
No, that's amazing. I love that you use the word choices as well, because it's so easy. It's something that we at the OMVP really believe in, that, you know, women need very much advocate for themselves, and it's about their choices. That was really, really nice to hear. You mentioned polycystic ovarian syndrome, and obviously that immediately made me think of endometriosis as well. Are those factors with recurrent pregnancy loss?
There's certainly factors in pregnancy loss. So both polycystic ovaries, so polycystic ovarian syndrome is certainly associated with miscarriage. Endometriosis is also associated with miscarriage. It's not so clear that they're associated with recurrent pregnancy loss, but as we've already said, you know, somebody can have miscarriages down to a number of different factors, and it's highly unlikely that I'm going to be able to tell you the absolute cause of each individual pregnancy loss. So certainly they're in the mix somewhere, but I think they're not distinct causes of recurrent pregnancy loss, if that makes sense.
No, that is really helpful, thank you. So in terms of supporting pregnancy sort of after loss, you said that you have somebody who sort of works with women, birthing people who have experienced recurrent loss. How does that sort of, because obviously I don't want to sort of assume anything, but sort of how would that work, just so we can give people watching this an idea?
Do you mean, sorry, in terms of the counselling service, or in terms of the going forward when people are pregnant?
Going forward when people are pregnant. I mean, so the counselling we have covered, Kim from Petals was saying apparently they are available as well, which is really good to know as well. But just, the going forward, really.
So anyone who's already accessed our clinic has open access when they're pregnant. So again, just because going around the houses and talk to GP who then has to refer you in, etc., is not really very helpful, I don't think. So we give people open access to our clinic. I work with an absolutely fabulous advanced nurse practitioner called Debbie, who taught me to scan and taught me an awful lot 20 years ago. And so Deb and I have worked together for years, and she is the mainstay of the service when women are pregnant. So I also have my secretary's part of that. So my secretary will see, take calls from women, take emails, we're pregnant. So we get people into the service at about 6 weeks. And then obviously if somebody wants progesterone, for example, we'll get that sorted. And then really it is a case of what individuals want, because not everybody wants the same thing. Many women want to see Debbie on the nose every 2 weeks until they get to whatever point they start to feel a bit more comfortable about this pregnancy. Some women, however, don't want to scan, they don't see the point. They know it doesn't actually change the outcome and it makes them feel more anxious. So I think we try and individualise it for what works for individuals and couples. And my view often is it's a case of sort of muddling through that really horrible few months till you get to a point where you start to believe this is going to be okay. And Debbie particularly is fantastic at doing that, I think.
I can remember that those scans for both of my successful pregnancies, they were so important, but I can remember every single time lying, and I think I had one with you, and just saying, is it there? Is it still there? Is it still there? And I can see how some people don't want to do that as well.
Yeah, and I think it depends on who you are. For some people, I think the anxiety levels move up, and then hopefully we do a scan and we just about do that for a little bit, and then they start doing this again. And that's all we can try and do, is just help a couple get through this tricky bit.
That's absolutely fantastic. You mentioned you've got studies. It might be quite a nice place to ask people if anybody is interested in. Have you got any studies on the go at the moment?
Absolutely, we do. I say that we're just getting them back up and running because everything was stopped because of COVID. But I think there's a sort of reality hitting now that we're going to have to continue because it's not going away. So the major things that we're doing at the moment is my own research group. We're really, really interested in immune cells in the lining of the womb. So some of those cells that we were just talking about, NK cells, but we're very interested in other immune cells, T regulatory cells, B cells. There's a whole set of immune cells in the lining of the womb which people don't really understand. So there's a study called the PIP study that we're doing that's looking at immune cells before pregnancy. We mentioned there's a study called ALIVE2, which looks at whether a blood thinner heparin is of benefit in the population of women who have inherited tendencies to blood clot. So if you've been through my clinic, you may have been tested for something called factor V Leiden, something called prothrombin gene mutation. And in these cases, we know that they're associated with miscarriage. We're not very sure whether treating them helps. And so in those patient groups, there's that study ALIVE2. We're about to start one of the Tommy's studies called the CERM trial. And that's a study that's looking at something called plasma cells, where we think there may be low-level inflammation that may be associated with recurrent pregnancy loss. And if we pick those cells up from an endometrial biopsy, then women would be randomly allocated into the treatment pre-pregnancy with an antibiotic called doxycycline or a placebo. So we've got lots of research studies undergo, at the moment, and really keen that people take part if they can. And finally, the other one is something called Hypatia. So that's for women with the antiphospholipid syndrome. And there's a medication called hydroxychloroquine, which again, that's a drug that's been used safely in pregnancy. And the aim of that study is to see if the outcomes for those women are improved with use of this medication, hydroxychloroquine. So there's lots going on if people are interested in taking part.
No, that's amazing. Thank you so much. It's just good to know it's all in hand, because I know it's sort of, certainly before people started talking about baby loss, it did sort of feel, that it was one of those subjects that no one really talked about. It was also under the rug, wasn't it?
And we all say it to each other, don't we? But as soon as you talk to somebody about having had miscarriage, everybody goes, "Oh God, that happened to me," or it's amazing how much of an unspoken thing still.
It really is. What was it that I'm asking you to go way back now. What was it that sort of got you interested in this kind of line of research and work?
So I was initially, once upon a time, quite a lot of moons ago, worked as a research fellow at Oxford Fertility. So, and a lot of my training was in IVF. I've also always been quite interested in immunology. So I did my sort of PhD in that area of immunology and recurrent pregnancy loss. I've always found women who've undergone recurrent pregnancy loss a really, I suppose, rewarding group of patients to work with, partly because I think it drove me mad, the bit of, oh well, crack on, it'll be all right. And although I don't know that we have so many answers even now, I think it's really interesting looking for the answers, but I also think it's really valuable helping support those people through whatever the outcome of that next pregnancy is. It's always something that's interested me.
Oh no, we are so lucky to have you. We really are. You're an incredibly valuable resource to us here in Oxfordshire. So, and of course we have partly you to thank for the early pregnancy unit as well, I believe. That was your brainchild.
Yeah, so the early pregnancy unit is my it's probably the thing I'm proudest of. Clearly it's very little down to me, because it's absolutely down to the fabulous nurses that work there. I think I started that idea back in 2014 when I was appointed as a consultant at the John Radcliffe. But I started that idea because I looked at a couple of fabulous nurses that I knew could do an amazing job if they were let loose to do it really well. And so we've been really lucky. We've built up a brilliant team of people who I think run a really good unit that again, I think puts women at the heart of it.
Yeah, it's so important, because I know before it was started, I can remember going in and you had to go into the women's centre and you had all these bumps everywhere, and it could be.
And again, I think that idea got in my head because once upon a time the fertility unit was also at the IVF unit was also at the John Radcliffe. And you just used to watch these women running the gauntlet of passing everybody in the maternity unit, and it for me it wasn't okay. And I always felt the same thing about the miscarriage clinic. I remember many years ago, a colleague did some work with the Miscarriage Association where they'd interviewed women, and it was just the theme that came up time and time again. And it's something that can be changed. Even a woman undergoing a miscarriage is normally physically relatively well. Doesn't always happen. There can be real problems, but you don't need to be coming to a hospital. And I think Rosehill is a much better environment for women.
No, it's such a terrific resource. So thank you for that. That has been absolutely brilliant. Do you have anything that you wanted to add? I sort of worked through my list of questions here. I'm not sure if there's anything sort of hugely kind of relevant that you can think of. I think we've gone through all the.
You covered it really.
Yeah. So obviously, because we were going to be doing live, people think of questions after.
Yeah.
Would it be all right if we get some people who message us with some more questions for you? If I can either forward them on, or we can sort of, I can send you some screenshots. Would that be all right? And then I can always message those people back. And brilliant. Thank you so much.
You're welcome.
It's been absolutely brilliant. And yeah, just thank you very much.
Nice to talk to you. Take care. Nice to see you.
Well, bye.
Take care. See you. Bye bye.